You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
Welcome to the MaternalRx podcast on the Pharmacy Podcast Network, where pharmacist expertise meets interdisciplinary collaboration to overcome today's devastating maternal health crisis. I'm Danielle Plummer, pharmacist and antepartum doula, and am overjoyed today to introduce Dr. Eboni January, affectionately known as Dr. EJ, an award-winning, board-certified OBGYN, best-selling author, media contributor, and America's maternal and women's wellness expert. She has delivered more than 8,000 babies and is recognized nationally for her leadership in maternal safety, women's health education, health equity, preventative care, and faith-informed healing. She's founder of Empower Labs, Empowered Motherhood, Empower Mama, Private Summer, and Fertile Faith Initiative, a comprehensive ecosystem of products, courses, clinical programs, and community partnerships that support women at every stage of life. I read about these statistics with Dr. EJ before I met her, and at a glance, oh my goodness, 8,000 deliveries, board-certified OBGYN, 3 best-selling books, more than 20 national media features, over 25,000 followers on social media, and I'm sure quickly growing, featured expert on health, hormones, pregnancy, and preventative wellness, founder of 4 women-centered wellness ventures with partnerships that cross a large spectrum of patient populations from churches, universities, hospitals, and corporations. Dr. EJ, thank you so much for joining me today. Is there anything you would like to add? And following that, what an introduction, what experience and wealth of knowledge that you bring. Can you share a bit about your journey as an obstetrician gynecologist and what led you to focus so deeply on maternal health equity and prevention?
Yeah. So one, thank you for having me. And thank you for that amazing introduction. I'm sure we'll get into more, about me. And I guess, the first thing is how I arrived at becoming an OBGYN and then specifically in this space of advocating for patients. And so I started to get the idea that I wanted to be an OBGYN when I was 14. At that age, and I'll tell you why specifically then, my grandmother, who had given life to 14 kids, her body was starting to deteriorate. She had multiple strokes, she was in poor health, and I watched my aunts rotate and take care of her. At the same time, my stepmom was pregnant with my youngest sister, Alyssa. And to see the body change, it was like full circle, right? I was young when my youngest siblings were around, right? So it was like really 4 of us that were all together, right? And then I had an older sister who was, 8 years older, who, she was young adult at this time. And then my youngest, to know what life was like when she wasn't around. And now all of a sudden there's this baby. And so to see the body change to deliver, to give life, but also to watch my grandmother's body, who had given life to so many beings, to see her deteriorate and to watch the women in her life take care of her, it just really brought things full circle to me and had a huge impact on who I would become. I specifically at the age of 14 said that I wanted to be an OBGYN, and I'll tell you why. Most people just think we deliver babies, but we don't just deliver babies. We take care of the whole patient. We take care of chronic issues. We do a lot with regards to preventative health, and then there's surgery, right? There's office procedures that we're able to do, and then there are also surgeries that are not C-sections that we do from a gynecological standpoint. So fast forward, I went into college and med school wanting to be an OBGYN. And when I started practicing, I practiced for FQAC, a federally qualified health center, where we dealt a lot with low-income patients. When we talk about the social determinants of health, I knew what it was before it was even coined a phrase. And so I started to see women who knew nothing about their bodies, right? But they knew a lot about being a mom, being a significant other, being, an employee, or being, even an entrepreneur, but they didn't really know a lot about their bodies, and they didn't know a lot about preventative health whatsoever. So I started seeing a trend where I was having overweight women, young women, right? You know how it is, like after you've had babies, or as you get older, you gain weight. These were young women, some that hadn't even had babies yet. They had excessive weight. So I realized in those moments that they didn't know what proper nutrition was. They didn't know what proper eating was. And, many times they were telling me that they only ate once a day. So I said, not eating is worse than overeating. And so I developed a text weight loss coaching program in response to my patients so that I can remind them to eat workouts that they can do in the home, considering that they're busy, considering that they're everything to everyone, right? And so I started seeing not only were they overweight young, but they were managing so many things, and their health took a back seat to everything else. So fast forward, now I'm starting to deliver more babies, and I'm starting to see things that women knew nothing about as it pertains to pregnancy. Even if it was their second or third pregnancy, they didn't know. And so I'm educating in the exam room. I'm drawing pictures, and they're like, "Oh, Dr. January, can I have this piece of paper that you drew on?" And I said, of course. I have it up here. And I would point to my head, like, I have it up here. Of course you can have this. And so then I started doing more in the community. I started, maybe speaking on ovarian cancer, cervical cancer. I was on the radio. I ended up getting my own Fox 2 segment, my own podcast at CBS Radio that we called The Wellness Wheel. And so I realized that in order for me to best do my job as an OBGYN, I had to heal them, and I had to educate, and I had to make sure that they knew that they were a part of the team. There's so many times that I had women that would come in my office and they had been on the same medication for 10 years and they didn't know the name of it. And I said, that's crazy. But they would always reach for their purse to get the pill bottle out, and I would put my hand over the purse and I said, let me tell you something. Don't let anyone give you a pill bottle and you don't know the name of it or you don't know why you're taking it. This is just as much my responsibility as it is yours. I would tell them, I don't want you all complaining about doctors and nurses if you're not doing the job either. Don't get me wrong. I do my fair share of complaints about us as well. But I'm telling you that this is a team sport. And so that's when I started really taking a look at myself and the type of doctor that I wanted to become, right? To say, okay, I don't just want to push pills or my solutions. I need for us to think this thing through, and I need for you all to do your own homework and also keep track of your symptoms so that I can best serve you. But I want you all to do the work as well. That means eating right. That means going to the gym. That means knowing more about your health than you know about your favorite reality show star. This is how I talk to my patients, and they talk to me the same, right? Very honest, and I love that. Like, when you work as much as we do, they become your family. These are the conversations that you have to have with family, right? That's how I started really walking into the type of OBGYN and physician that I would be. And it was one that helped to prevent disease, reduce risk, but also educate and understand that my patients were a part of the team. That's how I started advocating more for patients, because I said, well, it's one thing for me to educate them, but it's another thing for me to also talk to other doctors so that they can understand what the patients are going through, because we don't know what we don't know. You don't know if you're biased. Some bias is conscious and some is unconscious. That's when I started getting more into the advocacy space.
So powerful. You just shared so much. I don't even know where to begin with this. Your patients, I would say, are so lucky to have you and to have come across you. But it's interesting to hear your story, how you had grown from the time you knew you wanted to be an OBGYN. And then when you start working with these patients, you said, I knew the type of doctor I wanted to grow into, but it seems like you already were at that point. The way you communicate, the way you share, the way you can relate to who they are, their experiences, how they spend their time, and then transition that to how can we empower them to take care of themselves. I heard you say online, you make sure your patients are health literate and that doctors are culturally competent. And you just gave examples to bridge that gap. So you're working on both the patient side and your community as a physician. You said the rights and the risks are the most important things. Tell me about this best-selling book you wrote, Empowered Motherhood.
Once again, when we talk about social determinants of health, I want to break that term down just for the people listening who don't know what that is. These are things that are in your environment that affect your health that are not necessarily the delivery of health care. If you can't get to the doctor, that is a social determinant of health, transportation issue. If you can't eat the right food, this is social determinant of health. If you are not necessarily educated, just in general, this is a social determinant of health. Health literacy, meaning your ability to understand what we say to you, apply it, is just as much of importance as any of those things, right? I'm a fixer, right? Everyone comes to me to fix things, even in the family. I've unfortunately become a young matriarch due to passing of my mom, my aunt, my grandmother in just a short period of time. But when you come to me, I'm a fixer. And if I can't find something and I know that you know that something's wrong, then I have to be able to identify it, whether it's health or whether it is a financial issue, a mental health issue. What I started seeing when people were coming back to me after, I'm giving them my best and things are not changing, I realized is that maybe they didn't understand what I was saying to them. So I had to break things down in a simple format. As I was stating before, that I'm a visual learner, so I was drawing on the paper that we pull across the exam table. I was drawing on those things. People were going home with these big pieces of paper, When I wrote the book, Empower Motherhood, it was two reasons, not just because they didn't understand health and what we were saying to them, but also because even the educated woman doesn't necessarily feel comfortable asking the doctor questions, right? So this was just as much for the patient as it was the doctor, because oftentimes we keep bumping our head not knowing why the symptoms aren't improving or why the numbers aren't changing. And it has a lot to do with what is going on at home or their understanding of what we're saying to them. It's to bridge the knowledge gap, because now as a doctor that's seeing 40 patients in the exam room, giving her a little bit of information or educating her within 2 minutes doesn't seem so cumbersome, because she has a foundational understanding of what I'm saying to her. Understand that in this book, there are some big words, but underneath those big words are the explanations, because when doctors say these big words to you, you have to be able to understand what they're saying, so that when you go home or when you go into an ER or a OB triage and your doctor's not there and we ask your medical history and you say, oh no, the pregnancy's been normal, but you've gotten the diagnosis of preeclampsia, but you didn't understand the word. Right. This is what this book is for. It's for you to be able to understand what we're saying to you, to bridge that knowledge gap so that doctors can educate within a couple of minutes. You understand because you already read about it in this book. And so that's what this book is for. There's pictures. I walk you through the pre-pregnancy, safe medications, what's safe to eat. And obviously this is not the end all be all, because information changes and I don't know everyone's health history. This is so that you can have an intelligent conversation, an informed conversation with your doctor, that you can see what a TOLAC is versus a VBAC. And if you don't know what that is, I'm going to challenge you to get the book. You should know what these things are. You should know your risks. You should know what the difference is between baby blues and postpartum depression. That's what this book is for, is to close that knowledge gap, to make you informed, and also so that you understand that you're a part of the team.
Incredible. It sounds like everybody needs to read this book. One of my previous roles, I was working in the space of preeclampsia. What I found was so interesting when I said the word preeclampsia, not to the health professionals, but when my friends, family would ask me, what is it that you're working on now? They had known it under the name toxemia, the older friends, right? Dr. Jenry, how would somebody purchase your book?
I'm going to answer that question, but I want to go back to what you just said. You can get my book on Amazon. Actually, it's on Kindle as well. And I'm also going to have a downloadable version of it coming soon so that you can just go straight to my website and get it. But I also have courses. I have a master class for labor complications. These are things that you should do before you get to the labor room. Getting the book and knowledge. I have downloadable guides for men, for doulas on my website. I heard that you said that you're a doula. We need support persons to gain the knowledge so that you can best support a pregnant woman. Because I'll tell you this, sometimes pregnancy brain is a thing. You get into the ER or the labor room and you forget certain things. But this is when that support person steps up and says, hey, oh, by the way, she does have preeclampsia. Oh, by the way, she has a bleeding disorder, and that could prohibit her from getting an epidural, because if she gets one, then she may get a hematoma and potentially be paralyzed. So this is where the support person has to step up. When I talk about a team approach, I'm talking about doulas. I'm talking about dads or significant others. I'm talking about, family members that should have an understanding of what that pregnant woman is going through and her medical background, her information, so that you can deliver that information information to us, and we shouldn't be offended by that, because I know that pregnant women don't always remember, right? And so I have these guys, and I have courses, and even I just taught a course in Las Vegas, and they got handouts, places where they can keep track of their symptoms, their blood pressure, their diabetes testing. If they have diabetes, they get a handout to keep track of their sugars. We need this information. This is data that helps to treat individuals, but we need support persons to know that information, or at least have a general understanding. It's like you said, every time I talk about preeclampsia, I did a video on my Instagram about how it used to be referred to as toxemia. And you just said that. And I say it all the time. It used to be called toxemia. And this is for like the older people who have daughters and granddaughters who are having babies. I just let them know it used to be called toxemia. Now it's preeclampsia. And it was toxemia because it affected every organ system. You can have headaches, spots in your vision. You can have excess fluid. It affects your liver. It affects your kidneys. It affects the baby. It literally affects every organ system. And that's why it was called toxemia, but now preeclampsia, because you can have seizures. Pre meaning before, eclampsia meaning seizures. So it's important that you gain this knowledge, support persons, not just pregnant individuals. Get it as a baby shower gift, but get it for yourself as well to support the pregnant woman. And it's available on Amazon.
Dr. January, you took on quite a task. So when we say we're a fixer, I'm a fixer, I'm a visual learner, but I think everyone that works in pharmacy, I'm guessing most physicians are fixers as well. This is how we're trained. What's the problem? How can I correct it? But it's normally on a smaller scale. You're changing something that has impact to improve healthcare for thousands, tens of thousands, 100,000s, potentially worldwide millions of women. And I am so grateful. The statistics in the United States right now are truly frightening, around the world as well. So the United States has the highest maternal mortality rate among developed nations, often ranking 55th worldwide in some reports, with up to 22 deaths per 100,000 live births. This is from the Commonwealth Fund study. Despite high spending, we know what it costs for healthcare in the United States. The U.S. rate is more than double that of most other high-income countries, with over 80% of these deaths considering preventable. You mentioned the work you are doing to prevent maternal morbidities and mortalities. Norway has zero. Granted, they are a small country in a more homogeneous patient population. Zero. In the United States, we see that large racial disparities in maternal and infant health outcomes persist. Pregnancy-related mortality rates among Black women are over 3 times higher than the rate for white women. Black, American Indian, Alaska Native, and Native Hawaiian and Pacific Islander women have higher shares of preterm birth, low birth weight birth, and births for which they receive late or no prenatal care compared to white women. Infants born to Black, Pacific Islanders, Alaska Natives have markedly higher mortality rates than those born to white people. And that was from this KFF organization. Mm-hmm. Very, very frightening statistics. You stepped firsthand into this environment, saw what was happening, started with who was in front of you and said, I am going to improve this. I'm going to make these change. And now you're doing this on a global level. Thank you so much for this undertaking, because it's a big one. It has to happen, and it takes people like you to get this education one-on-one and at a large scale to happen. From your perspective, what are the most misunderstood drivers behind these outcomes?
A couple of things. It's so multifaceted. The first thing is delays in care, gaps in care, and also understanding the patients that you serve and knowing when you need to release your ego and attitude with regards to your position and say, hey, this is a human being. I can be in this position one day as a patient, no matter what I look like, and say, okay, how do I best become a better clinician? And I'm not just talking about doctors. I'm talking about across the board. How do I best become a better hospital leader and improve my outcomes? How do I improve the systems? And I said this on a previous podcast, is that, a lot of times we point the finger, right? And if we're not pointing the finger and finding the solution, on the other side of pointing the finger is the solution, then what are we doing? We're just pointing the finger. But my grandmother used to say, when you point the finger, the thumb points back at you. So it's everyone's responsibility. So when you talk about delays in care, this is a patient issue, right? I want the patients to know the red flag symptoms and to act fast, what to go in for. I talk about this a lot in my book. One of the top causes of mortality, your blood pressure issues, cardiovascular issues, monitor these at home. When you talk about advocacy, use your voice and be unapologetic, but be respectful on both sides. We need to be more respectful to each other. Making statements like, I'm not feeling well. I need to be evaluated. This is a change from my baseline, but you got to know what your baseline is. Also, build a support team. As you stated, Danielle, you're a doula, but you don't necessarily just need a doula. You can have a partner or friend who is educated, a community health worker. I think everyone needs a pregnancy navigator, and insurance companies need to start paying for these pregnancy navigators to improve outcomes. And also keep all of your appointments. The other thing that I see is when women have had multiple babies, they think, oh, this pregnancy is going to be like the last one. And so they miss appointments or don't think that they need prenatal care. You absolutely do, because one, as you age and as you have more babies, things like postpartum hemorrhage become an additional risk factor. So understand your personal risk, high blood pressure, diabetes, whether you're overweight, if you have an autoimmune disease, if you have a bleeding disorder. These are things that you need to know about your personal history that are going to set you up for success, right? And mental health, because that's a top cause of morbidity and mortality, is mental health conditions. If you have a pre-existing mental health condition, address it. Get help now. Start planning for your postpartum period right now, okay? And also advocate for better health, better care. Interview these hospitals just like you interview anything else. Know the patient advocate numbers. Be okay asking for charge nurses. And as leaders on our side of things, we need to know we have to start using our voice and also start improving our systems. Look at what hospitals have good outcomes and start mirroring what they're doing. Make things visible like patient advocacy number, charge number. Start also evaluating the people who are delivering care. Just like we used to have the secret shoppers, remember those? Start doing secret shoppers to make sure that the training that you're having your staff do, that is being implemented. That's so important that we have to do these things. And also making healthcare easier for patients. That means we need peer navigators. We need to educate them so that they know your resources are here. Insurance carriers as well. Many times patients don't know what resources are available to them. They don't know how to make follow-up appointments. And this is where, as systems, we have to improve, because when you talk about gaps in care or delays in care, a lot of times these are systems. They don't know how to call, or it's difficult to get through for a mental health specialist or get set up for a postpartum visit to get their blood pressure checked. These things can be done before they leave the hospital. And I've seen it done. I'm licensed in 16 states. I practice in a lot of these states. And so I see where things are being done right. And I've seen where things are not done so well. And so we can make accessing healthcare a lot easier for our patients. You just think about being sick. And now I have to figure out how to make an appointment with this person or that person. Oh, they don't accept my insurance. This person maybe accept my insurance, but if they do, they don't have an appointment for 3 months. You get what I'm saying?
I don't just get what you're saying. You can't see me right now. I am beaming. Every single one of those, what you want to call them, pearls, facts, are so important. As women, we don't hear these things. Even in the healthcare profession, we don't hear these things, which is, even though I'm a pharmacist, why I got the doula certification. Insurances are now starting slowly to step on board and reimburse for doulas. ACOG just changed their guidelines recently to show you need to see your obstetrician when is best for your body and when you have access to get to that obstetrician, not necessarily on the guidelines that were set many, many decades ago. How do we empower ourselves? I was going to ask, you already answered it. It's really incredible to say, I have this power. I should be interviewing the hospital. I've never heard anybody say that. The secret shopper analogy is just brilliant.
Absolutely. We have to. You can take a tour of the hospital, ladies. You can absolutely do that. You can ask for these key numbers. Let's talk to people who are not pregnant, because I'm sure that you'll have some people listening to this who aren't pregnant. There are patient advocates for just anyone. They're community health workers. Check in with your insurance company. And then the ombudsman. This is someone who advocates for you on a higher level. Get their number. Their number is usually very accessible. And so just look it up. And I think that that's so important. And then like I said, as leaders, we have to make sure that we're not offended when we say things like this, because if we're worried about good outcomes, if that's the goal, is a good outcome, healthy patients, then we shouldn't be offended when someone gives us a solution to the problem.
Thank you. I've actually run into that when people have hired me to advocate for them. I'll call the ER. Sometimes they're very excited to hear from me, and then other times I'll just get that. Don't tell me what I'm supposed to be doing with my patient. My specialty being hyperemesis gravidarum. So I know if somebody's malnourished, I'll do something like ask for a banana bag because they're at risk for Wernicke's. But when you have somebody taking care of that patient in the ER, and I don't work at that hospital, it can go either way.
And I think we have to switch up how we speak to each other. Just in general, our mindsets, we are a team, right? I can tell you how many times I'm going to call internal medicine if I can't control a blood pressure. If this headache is not going away, I'm calling neurology. I've even called down to the ER before, and they're like, or they've called me and they're like, okay, we have this patient. She has this going on. I'm asking questions to get more understanding. And I'm like, okay, also she needs to see this person. And they're like, oh, are you going to come see her? No. I'm coming to see her. She also needs this person, because in my years of practice, I know that this also may be an issue. Many times when women come in, they just think everything is the uterus or the ovaries. And I can't tell you countless times that I've diagnosed kidney stones in women with pelvic pain and bleeding with urination, and they just thought that it was coming from the vagina, and that's not the case. So I think that it's important for us all to change our mindset surrounding working with one another, because I can't do what you do, or maybe I could, but I need an extra set of hands, and you specialize in this. Maybe I don't see this every single day. And it's the same thing with doulas and patients and their significant others. We have to change how we interact with one another, our mindset as well, because if the goal is good outcomes, then we need to put our egos aside.
Music to my ears. That's why I started this podcast, because pharmacists are often a forgotten entity in the healthcare collaboration team. And these are the ones that your patients, when they're not seeing their specialist, they can always walk into a pharmacy and ask for help. We are there at the retail space, in the hospital space, in infusion centers, and I'm hoping to close that gap so we can work with professionals like yourself who are one-on-one with those patients.
So absolutely. And then understand that pharmacists can also delay care as well. I've had this recently happen. I called in a prescription for someone, and they were worried about like my office number when I gave them my cell number. And then now this patient's suffering because there's a delay there, or maybe not understanding in your clinical training that one particular medication was used for one particular disease, but there are medications that can be used for multiple things, but maybe your experience didn't see it used in another way. That happens as well.
This is a really important concept, and I'm glad you're bringing this up, because my training as a pharmacist is very different than many others. And the retail workspace is not the pharmacy space that I work in a very long time, and it's changed a lot. I don't ever want to see that or hear that a pharmacist delayed care. So that's another reason I started the podcast, was to educate. What can those retail pharmacists do when you have 30 seconds per patient coming to that counter? I like to recommend that patients choose which pharmacy they go to, find the ones that can offer you the time, get those questions that would remove that barrier of delayed care. That should never happen.
This just happened to me last week, and the patient didn't tell me. 3 days go by, and I'm like, did you get your prescription? They said that it wasn't there. I'm like, I called and spoke with the pharmacist directly, and then they called me to make sure that the office number lined up, and I told them, look, I'm licensed in multiple states. This patient needs this. And keep in mind, this was a diabetic, and I couldn't believe it. And so that's another conversation for another day, but it ties into the whole delays in care. I was busy, and I had to take a couple of calls from the pharmacies, and they still didn't do it. They still didn't fill this prescription.
Look into that one for sure, but I know your time is pressed. So if there's anything I can do to help you figure out what happened there. Retail pharmacists are kind of flying blind when they feel something, their license is at risk, and if they don't feel 100% comfortable, but that's where we need this education. Just a few quick questions. What's one myth about pregnancy or women's health you would love to retire?
That every pregnancy is the same. It is absolutely not the same. I want women to know that, if you think that your second or third pregnancy is going to be just like your first, that's not always the case. And a lot of times women don't necessarily come in for that reason, or there's delays like, oh, I'll be fine. This happened with my last pregnancy, or my last pregnancy was normal. Those kind of things. I've seen a lot of poor outcomes that way when you think that every pregnancy is the same.
Absolutely. What's one thing every woman should ask her OB but doesn't?
What are my risks?
I
You
love
have to know
this.
what your risks are. For example, if this is your third or fourth pregnancy, what are my risks because this is my third or fourth pregnancy? If I'm a little overweight, what are my risks because I'm overweight? If I want a C-section, what are my risks? Like, let's start prepping for what's to come, as opposed to when it happens, everyone's shocked or not necessarily prepared for it. I think that that's one of the key things that we should talk about, like, what are my risks? And we don't talk about it often.
I've never heard that question asked from a patient. Absolutely. Thank you for bringing that one to light as well. And my last one for you, are there specific red flags, either physical or emotional, that women should never ignore during pregnancy or postpartum, even if they're told that's normal?
Sure. Severe headaches and vision changes, chest pain and shortness of breath. If you have sudden swelling in the face and hands specifically, heavy bleeding, postpartum hemorrhage is a top cause of mortality and morbidity, decreased fetal movement, pain specific on this right side, right upper abdomen. Those are signs that you definitely want to look out for. And just feeling withdrawn postpartum, you're not interested in baby, you're not interested in, just doing anything. That's also be a sign of postpartum depression. And so we don't want you to go down that path. And so speak up. And for the people around them, if they're saying that they're okay, I need for you to watch them a little bit closely if, they have any of those signs or symptoms as well.
You so quickly just responded to that question. Everything you named is so, so important. My other question for you was, what can we do as healthcare professionals differently to support maternal wellness, close those equity gaps within our own roles? And I think you just answered all of that. Is there anything else you'd like to add?
The main thing is healthcare professionals. I want to reiterate, if the outcome is wanting to be good, then we have to put our egos aside and we have to work together, not just as healthcare professionals, but improving the system and also including our patient as a part of the team.
So powerful. Thank you so much, Dr. EJ. To connect with you, what's the best way if people would like to access your courses and learn more about what you do, follow you on social media?
Sure. You can go to my website. It's drej.com. That's doctorej.com. My email address is drej@drej.com. That's doctorej@doctorej.com. And I'm pretty active on Instagram and Facebook. That's Dr. Eboni January. That's doctor spelled out, Ebony with an I, and January just like the month. And that's both on Instagram and Facebook. And then also on LinkedIn. Many people reach out to me on LinkedIn as well, and that's just Dr. Eboni January.
Dr. January, thank you so much for taking time today to speak to us. I know it's an emotional day for you. Everyone, thank you for listening to the MaternalRx podcast. I am Dr. Danielle Plummer, advocating for better maternal outcomes through pharmacist-led collaboration. I'm eternally grateful to Dr. January for all the work she is doing both on a patient level and on a global scale. And I think the best is yet to come. Thank you so much.
Thank you. Thank you for having me.